Good evening, my friends. I'm happy to be with you again, and I would like to thank the organizers for making this possible to share with you my thoughts on PRP and beyond. Again, this was the announced title, and I took the liberty to add some more content to it as we move on. For those who I have not had the pleasure to meet yet, this is some of my background and disclosures. I was lucky to meet a lot of great physicians and students during my career, and I was very proud when I was mentioned and nominated as International Professor at Max Planck for the Ortho Region Group. Had the honor to be an adjunct professor at the University of Queensland and supporting PhD students. Published quite a bit, and currently I'm the Senior Director of Medical Affairs for Bioventus in Durham, a company focusing on non-surgical natural healing therapeutics. So what is I would like to share with you tonight? First of all, make clear that there is, in my opinion, a disconnect between PRP utilization in 2025 and where we got started, at least where I got started in 1989, and from there on see what the influences are on the various healing cascades and what the impact is on reported patient outcomes. Next, I would like to touch on one of my favorite new topics is tissue homeostasis, to demonstrate that there is a connection. There's a connection between the brain, the bone marrow cavity, and what we can see in our PRP based on the platelets. So we're going to look further than leukocyte poor and leukocyte rich PRP. So I would like to address the differences between immature platelet fraction or high density fresh platelets versus the senescent platelets, and touch as well on the mean platelet volume, MPV, and what it means from a cellular density perspective. So in other words, at the end, when I'm done, I hope we can agree, we can rethink, redesign effective PRP formulations based on the data, the scientific proof I'm going to provide to you as to where we are. This is, a highlight of my career. I got started here in the bottom of my personal roller coaster in orthobiology. I've been active for quite a while, like I mentioned earlier, I was lucky to meet a lot of people, to be invited to do my PhD at the University of Utrecht, a very formal thing. I had the opportunity to present for the United Nations in 2009 together with Ellen Mishra. Built wound care clinics using only biological therapies like hyperbaric medicine combined with PRP, bone marrow and adipose tissue. And from there on, my own personal roller coaster kept on moving onwards with, again, my installation as international professor at Unimax, invited lectures at Harvard Medical School, be part of the academy in both Spain and Brazil, and my recent appointment at Bioventus. These are some of our papers we published, and like I mentioned, this is a paper that was mentioned to you in the announcement, and I would like to add to it, again, some thoughts in a paper that we have submitted looking at the homeostatic blueprint. In other words, what is it that patients give us in order to make a good PRP? But first of all, I have to thank all my Brazilian friends, and there are many and plenty. This is just a very small representation of many friends I was able to meet. And as you can see, even, some 20 years ago when Professor Laan and I met for the first time, there are some differences on the top of our heads. Our hair change over time. Get thinner, it's changed its color to silver, but the main thing we never forgot is we need to do our utmost best for our patients. So I feel very connected with you all in Brazil. I'm sorry I cannot make it at this stage too often out there. You're in my heart. I look forward to collaborations. I look forward to better time for visiting and spending time with my fellow faculty, professors, and students. But it will come. But I'm very grateful. Thank you, Ortho Region, for adopting me from Europe and the US to be part of your circle. Thank you. Autobiological preparations. What do I feel we need to address? That is, first of all, what do we have available? What kind of products do we have available? So we can have a distinction between cellular products, acellular products, and also the combination of products. And we can look at blood-derived preparations like PRP, like platelet-rich fibrin, MSC-based, both on bone marrow and adipose tissue. But let's stick for now to PRP. I'm going to save you all the classification systems that we have in place, where people try to get an understanding on indications, get an understanding on the methodology. But I think we don't agree too much on a global level, but we can agree that a proper definition of PRP is that a small volume of plasma with a high number of platelets, and that number has been defined as a platelet concentration of 1 million platelets per microliter or 1 billion platelets per milliliter. And that has been recognized by various papers already more than 20 years ago, 25 years ago, by Professor Marks, and recently also by a group from Mayo Clinics, indicating that that definition would be a big difference. But unfortunately, what we see is many papers being published, and this is just a summary of papers that have been published with reported outcomes not positive when using PRP technology. So that's a concern, that's a significant concern, and we have to understand, why is this happening? Why do we have failing studies? And even up until, this year, we still see studies being published where the outcomes were not positive, no positive reported outcomes. And we need to understand, we owe it to our patients, why is this happening in 2025? And it will happen in 2026 as well if we don't have a better understanding. So, being in this field for 35 plus years, I still feel we are scratching the surface of the iceberg, and we need to make a deeper dive. Especially what we did in one of our studies is looking at a so-called dose-response curve. And what this curve shows us is there are failing studies, as you can see in the pink, and in the blue we see some positive studies, that it is related to the number of platelets injected, the total deliverable platelets in a pathoanatomic tissue, and this in tendons of tissues. So one of the landmark studies from my dear friend Luca Podesta was published 12 years ago, and he even had no clue what he was doing. He told me that very often. He had no clue. He made PRP, leukocyte-rich PRP, and in the aftermath, when calculating the number of platelets injected in these patients was 4 billion. But from the reported outcomes so far, studies starting at 2.5 billion platelets per milliliter made a clinical significant difference. And the curve changes when we look at osteoarthritic conditions. So these are just a couple of studies that indicate PRP therapies might work, but only after 3 injections or 4 injections. And the difference really is the total number of platelets injected. So when a physician decides to give multiple treatments at a lower dose, the injection is at a lower dose than 10 billion platelets, the patient will not see a positive response. That only happens once that mark of 10 billion platelets is given, from what we understand now, a pain-killing effect as well as a functional repair perspective. We see positive results of PRP intra-articular injections in NeoA KL23 if the dose is above 5 billion. But that's only a pain-killing effect, not a functional repair. The functional repair starts to kick in after 10 billion. And this is the landmark paper, I think, for Himanshu Bansal, which I had the pleasure to spend a weekend with at a conference. And we discussed many things about his paper and also his well, not too clearly mentioning reasons why this would work. So, but that's another discussion I would love to have with you at the next stage. So now, with the 3 injections of 5 billion platelets, do we reach a maximum? Is there going to be an adverse effect? I don't think. We don't know. But keep in mind, from the study published from Kamochi, they needed 36 tubes. And that's quite a bit of an investment in 4 office treatments. And I know in Brazil, you have the ability to work with smaller volumes, and what I have seen by the work of Professor Lana and Dr. Ludi Pires is you can keep up with high dosage, high profile PRP with multiple test tubes, so you would not need to do 4 office treatments. So again, different tissue types, different responses, and that brings me directly to the paper we published already 3 years ago. How can we differentiate PRP therapies, looking at formulation and dosing? I believe there is a disconnect in PRP platelets. What I believe is, based on the work we have done, based on the work you have done in Brazil, is do we have the right platelets in our PRP? Do we have the right platelets in our PRP? In other words, there is a mix of platelets in PRP. Like you see on the left, we see the young and active platelets and the old and senescent platelets. And this entire process happens in a time span up to 10, 12 days after platelets have been released from the bone marrow cavity, right, from the megakaryocytes. So this was an interesting paper a couple of years ago, looking at subtypes of platelets and how these different platelets respond to inflammatory settings. And that to me was an eye-opener, right? Looking at, hey, the body knows something we don't know when we prepare PRP. So when we stick in a needle, when we use our PRP and we are ready to inject it, the question is, do we have the right platelets? That was the thing that kept me busy for a while. As well as, well, what is it that we are missing with our PRP preparations from an effectivity perspective? And then I had some conversations with my old university, and we're looking at what we call the tunneling nanotube system. In other words, how can cells communicate content from their mitochondrial to specific molecules to exosomes, from one side of a pathological area to another. And that's called by the nanotube system. And old and senescent platelets lose that ability. They lose that ability to transfer content from one cell to the other, even from one platelet to the other, or from platelets to mesenchymal stem cells. So the recognition that, well, platelet content can be moved in a pathological condition is a great finding, especially if you realize that the older, the smaller platelets do not have that capacity. It might have an effect on our PRP outcomes. So this is just a summary from when I got started. The bigger differences, right? We used bigger needles, we made PRP, we had higher volumes of PRP. It was always red. You're always looking at Lucas and Reg PRP. And then something weird happened. We started to use smaller centrifuges. We started to use smaller needles. We started to draw lesser volumes, right? And when I reviewed the data I was able to access on one of my old computers, then this would be the profile of PRP, where we use higher volumes of whole blood, but also higher volumes of PRP. So the good news is you can take more blood, you'll have more blood to work with, and that's simply a good thing. And when we look even further from a historical perspective, then we transitioned, right? We transitioned from a surgical setting to arthroscopic use of PRP, to non-surgical interventions of PRP. And when we compare these data, we see completely different laboratory data. We see completely different PRP formulations, we see completely different platelet numbers, and that's simply related to the fact that we went from bigger machines to smaller machines, from more blood volume to less blood volume. And that has a huge impact on what we can deliver to our patients. So just keep in mind, from a historical perspective, surgery, arthroscopic to non-surgery. Great picture, isn't it? It's a revolutionary picture from one of the bigger battles here in the US. And I show you this just to understand, did we miss, as a clinical and scientific community, did we miss the orthobiological revolution? Because we keep on fighting on an international level, a scientific, academic level, between one type of PRP and another type of PRP, and we created all of these, well, different arguments, so to speak, when we prepare PRP. And the thing is, I don't think that's a wise thing to do. We got, well, positioned wrongly, and this is what I see the reason for. When we got started with the intraoperative fully buffer coat product, various pathways, various highs, and where we are now, that's all being related to a study in 2010 by Professor Dragoo. He did some animal work, he did some lab work, and one of the early conclusions was that leukocyte-rich PRP induces inflammation, and that's not a good thing. So the definition of leukocyte-poor, leukocyte-rich PRP was born in the 2010s based on a very small study, and we are still hunting that conclusion now when we look at the definitions of PRP, whether it's pure PRP, leukocyte-poor or leukocyte-rich PRP. And I don't think that's fair. I think we need to look further. So that's why we came with this paper to the conclusion, one size of PRP does not fit all. It does not fit all of our treatments that we would like to do, that we can do. So please get rid of it, because we need to make different formulations, right? We need to have different areas to treat, as you can see in this slide. So this is my knee in 2022. I had some pathologies, as you can see, but we use different kind of PRP formulations. And actually, on my booster not too long ago, I had an intra-articular injection, and you know what? It was leukocyte-rich. I didn't want to have any leukocyte-poor anymore. I wanted to have the full load of regenerative platelets, and I want to have the full connection with my white blood cells. Because when you understand the dynamics, the synergy between PRP platelets and white blood cells, then there is no other option. And we need to go back, therefore, to the differences in outcome and the initial experiences as well, when we look at, well, what was done in the past, right? It was all leukocyte-rich. So yeah, I had a very successful procedure done, as you can see it here, an extruding meniscus, legs, MCL. This was 9 months later. The tear was gone, the MCL was reorganized, the edema was gone, and I'm still very happy with the knee. Thumbs up for the procedure, thumbs down if we do not recognize the fact that we need to consider dosing aspects. Let me make a quick tour, which we can follow up later. Great paper published by the group from Medzitov out of Yale, looking at tissue homeostasis, and we never discuss it, right? But these are great references for you when you look at the definition or for the connection between the brain and ultimately what you're injecting with PRP. So great papers, and let me try to explain that for you, how the nervous system, both afferent and efferent nerves and the sympathetic nerve system and the connection with the brain ultimately regulates our healing. So this was a great paper. The brain is at the next frontier to better understanding the relation of hematopoiesis for future modulation and treatment. This was not directed towards PRP, but I'll hope to show you in a minute that connection is a very valid one, even if we do non-surgical therapies. Another great one, so explaining how the brain connects to whatever is happening in the bone marrow. And when we understand the bone marrow and we see, okay, the bone marrow is activated. The bone marrow is activated in a way that it produces hematopoietic stem cell activities. It triggers ultimately, follow hematopoiesis, the megakaryocytes to produce large proplatelets, and proplatelets become ultimately released into the peripheral circulation as high dense platelets. So we know already there's a gut to brain access, but we also have a brain to bone access. So all of these access are valid. We never discuss it because we don't think they are valid for what we do in orthobiological preparations. Let me explain you this graphic I made. So we have a knee, sensory nerves. It's indicating, it's signaling something is going on in the knee. There is osteoarthritis, there is pain, there is dysfunction of the knee. So it's the sensory nerves signal to the brain, and then the brain to the sympathetic nerve system signals to the bone marrow. So all of a sudden we have a connection. We have a connection from a pathology to the signaling brain to a corrective way, trying to get a corrective measure to the bone marrow, releasing bigger platelets. And those platelets is exactly what we need. Those are platelets we need, well, to support what the patient is already indicating to us, systemic level homeostasis. The patient is trying to resolve his own pathologies. That's what's happening. So the bone marrow is releasing on a continuous basis platelets that are big, that are dense, in order to compensate for the situation in that osteoarthritic knee. So the pain-killing effects and the anti-inflammatory effects are more profound with the bigger platelets. Right? And these are just some supportive papers indicating how homeostasis is working. I think they're a great read. I really would like to advocate to you to read these papers, understand the mechanism of the signaling, how it works. I'm not going to do that on the mesenchymal stem cells, hematopoietic stem cells, and ultimately the platelets that are available in the bloodstream. So having that said, again, when you do PRP, you extract whole blood. Then you do the processing. And based on your processing criteria, you will be able ultimately to understand that a platelet is not a platelet, because the only way to move forward would be high density platelets compared to the older and smaller platelets. So let me explain that in a few graphics. Different types of platelets. Produced, released to the peripheral circulation, and when they get released, they are big. They are big, greasy platelets, and when they're about to die, they are very small. So there's a big difference between the bigger ones and the very small ones, and it all happens in a period of 7 to 12 days. These are some of the characteristics between the two different platelets, and you know what? It has been published. It has been published indicating what the definition of young platelets are, what they stand for, what their capabilities are. It's not something because we like a leukocyte-rich product. No, it's simply because biology indicates that, well, we have different types of platelets, and they all have different functions. So we know exactly how these platelets behave, what their regenerative potential is, when they are arriving at a certain age. And that's something that's quite difficult to comprehend, especially if you think that, well, platelets consist also, well, a lot of granules, dense lysosome, but they also consist of exosomes. And when you look at the deficits of cartilage pathologies, then we recognize a lack of microRNA 26A and B. That's the reason why there is, osteoarthritic pathological condition. And it's only in platelets that we recognize these particular microRNAs, but only in bigger platelets. And they are not present in bone marrow. So when you look then at the marker, which is given to you by lab analysis, then you see a marker called the mean platelet volume. And these papers here on the right hand side, they signify for what the definitions are, what the value is of the mean platelet volume, or the MPV. And another great paper for you as a reference, we're not going to go over it, is, well, what are the differences between young and old platelets, right? And these are huge from a repair perspective, an anti-inflammatory perspective, immune modulatory perspective, pain-killing perspective. The difference, the effect that young platelets have in non-surgical orthobiological care is huge, and has been underestimated for quite a while. Because this is the traditional assumption. This is what we think. I have a unit of blood, I centrifuge it, and then based on the density separation, as you can see, we have the different density levels, and that's where our PRP is, right? And then we got, well, the classical definition of the pure PRP, Leukocyte poor, leukocyte rich, all depended on where we take our PRP fraction from, right? But then, well, we need to understand, and the literature indicated to us, we also have different density ranges. We have different mean platelet volume ranges. And that is that the platelets then also can be in different structures because of their density. They can be in the red blood cell layer. So the leukocyte poor is here. The leukocyte rich is going to be here. And what it really indicates is that based on the density, we will have a more regenerative PRP. So when you look at what the literature indicates as what all these density figures mean, then the pure PRP, 90% of platelets are only located in the pure PRP and 38 in the leukocyte poor PRP. So we're missing quite a bit of regenerative platelets, which supersedes any concentration value. So therefore, the innovative approach would be consider high density platelets. Consider platelets that are located even a bit deeper into the red blood cell layer, and that gives you ultimately the platelets that are capable for both non-surgical and biosurgical to control inflammation, to be immune modulatory, kill pain, tissue repair. That is the area where the platelets are. It's not in this yellow area. It's not in this yellow tube. What is it? Purpley? No, reddish area. No, it's the area from a full red to full yellow. This is the area that holds, well, both high density platelets, white blood cells, and we know they work in synergy. So that's the area of interest, at least to me, and I'm pretty sure I'm with my friends in Brazil, where we share the same opinion, that leukocyte rich is a completely different product, and it opens way more abilities to heal a patient. So, my friends at AutoRegen, thank you again for this opportunity. It's always a pleasure to have the opportunity to lecture, to share experiences with, and this is just a growing list of very strong proponents, both in Brazil, outside of Brazil, globally, who believe that we can make change. We need to color differently, but I'm pretty convinced that we grow a community that has a different view on PRP application. Thank you so much, and I'm happy to take any question. Thank you.